Hi everybody, welcome to episode number 124 of Tough to Treat. And this is Erica Mello, and I will be solo this week. And I will be talking about and giving you some great clinical pearls on clues in your patient's narrative that will make your assessment more efficient and, dare I say, easier, and help you find the driver quicker. Okay, it is going to be, I want to take some examples from my own caseload, but give you things that you can really grab from your patient's history and how you can turn that into a really effective assessment. So I hope you enjoy it. Hi everybody, this is Erica Mello and welcome to episode number 124 of Tough to Treat. And as I mentioned in my intro, I will be doing a deeper dive into the power of your patient's narrative. And Susan and I have talked about this endlessly on the podcast, and it is a very important part of your assessment. I know we all know that, right? But did you know that there are actually clues in the narrative that will help you find your driver quicker? Who doesn't want a quicker assessment, right? I mean, we all have time management issues. How can we finish the evaluation and be on time, right? And it doesn't matter how many years of experience you have, it's still an issue with the time. You know, I've been seeing patients a very long time, and I see some really difficult ones, right? And time management is always, on my mind. And if I can figure out how to, get to that problem and get to that driver quicker, then I'm all for it, right? So I'm going to give you just a couple clinical case studies of mine, very short. This will be a shorter episode, but but to keep it simple, I'm going to give you some clues into what you should look for. And if you learn one thing from this episode, just think about either your patient's past injury history or past movement history and how that perhaps can influence your patient's current symptoms. Okay, whether you're seeing someone for the first time or whether you're seeing somebody and they've kind of plateaued and you just can't get them past a certain level. Maybe something's coming into it that you may have missed in the narrative. Okay, it all happens to all of us, right? So the first example or the first topic I would like to talk about would really be PMH, right? What's PMH? People always think of it as past medical history. For me, PMH is past movement history, and PIH is past injury history. I differentiate those out in my assessment, and I draw a little horizontal line, however you take your assessments, whether you draw or whether you go on a computer. Put a single line across whatever piece of paper you're using and do a chronology, okay? Your patient's first injury will set them up, okay? I'll use myself as an example. I had a left ankle sprain in junior high school, which was many years ago, and it set me up. I offloaded that left side for so many years. I had left-sided back pain. And so what I will tell you is that their first injury will set them up for a movement pattern and a potential injury history or potential down the line. Doesn't necessarily mean that their first injury is going to be their driver. Not so in my case. My compensations around that injury have become my drivers, okay? So that's what you're going to look for. That will set them up, okay? And to do it on a timeline, it may actually help you navigate the assessment a bit better, okay? So in terms of past movement history, I'll just use by an example. I talk about this actually a lot in my Decoding the Complex Patient course. So let's say you've got an example, or I have a patient here. He's probably in his mid-40s, and he came to see me with left foot pain. Basically tells me, Erica, I cannot sit for a long period of time in my office because of left foot pain. Okay, so We look at his past movement history. Movement. Collegiate rower, left sweep, right? Anybody who's rowed, I have not done that, but I treat enough of them. So anybody who's like a lot of rowing patterns, they're going to be bracing their scapula, bracing their thorax, right? Left sweep, he'll be biased to the left side. Did that for years, collegiate rower, okay? Now when he goes on, even when he does the erg rower, which is definitely more, centered, he actually still feels his symptoms in his foot, okay? When he gets on a bicycle, like he does some cross-country cycling, and he'll be in that very narrow base of support with his arms, okay? And what's very, very, very important with that is that when you have somebody who's had a narrow base of support with their arms and they don't really feel great in that position, there's something that is not adapting well in their upper extremity, like neck, shoulder girdle, thorax, right? He didn't feel good at all with that. Cross-country skiing made him feel pretty okay. You think about that for a second. Why would that make him feel better? So collegiate rower, not so great. His movement pattern, I mean. When he goes on the erg rower now, not really good. Cyclist, avid cyclist, narrow base of support with the arms, not feel good. Cross-country skiing, feel better. Why would that be? His arms are wider, for one, and his legs are wider. Okay, so he can adapt in his upper and his lower extremity. That's his PMH, past movement history. And I mean, you're looking for clues in their narrative that they've done this movement pattern for years. It's not like, oh, I just took up tennis years ago. Not going to cut it. You're going to see these significant ingrained movement patterns from people who've been doing this forever. Your collegiate athletes, your competitive tennis players. Even you're a person who's like in their 70s and they still play golf, right? They've been golfing forever. These are the movement patterns we're looking for, okay? This guy had an injury history, bilateral hamstring tears, bilateral calf tears, lumbar radiculopathy with a left foot drop. Remember, Erica, I can't sit, my left foot hurts, okay? That resolved, okay? Biceps tendon surgery and a proximal humeral fracture on his opposite side, his right side. These all make sense with his history, okay? Was his pain generator his lumbar spine? Probably, but this is really about the narrative and not really, these episodes about the narrative and not the assessment, right? So think about, okay, you've got this movement history, you haven't even assessed him, haven't even gotten him up out of the chair, okay? And you're thinking, okay, this is what I've got so far, in addition to several other questions you can ask. But I'm trying to give you some clinical pearls. He's a collegiate rower. He's got an ingrained movement pattern to that left side, okay? He has a problem sitting. What we know of rowers, what do we know of rowers? They brace their scapula. They brace their thorax. They're in this thoracic anterior translation, right? Their obliques are on fire. Their the retraction, their rhomboids are kicking in. That is their pattern. Okay, he had a left sweep, very biased to the left side. Okay, Erica, I sit and I have left foot pain. Am I thinking that maybe this movement history is a factor? Heck yes, right? So in terms of a priority list, we talk about this in terms of what regions of the body are you going to assess? What would you prioritize? Okay, so I'm just going to give you a couple suggestions here, and a clinical pearl. Any region of the body that has an injury history or a strong movement pattern has the potential to be a driver. So I'll repeat that. Any region of the body that has an injury history or a strong movement pattern has the potential to be a driver. Okay, we talked about his rowing, bracing the thorax, bracing the scapula. That's pretty high on my list for priority to assess, the thorax, right? That is almost my top region of the body. His injury history. Okay, hamstring, calf. You're going to look at his lumbar spine. I did a little bit. I see a lot of patients who've been elsewhere. So by the time he came to see me, his lumbar spine had been assessed and treated and wasn't getting better. I did look at it, was not high on my priority list. Because at that point, do you think his lumbar spine is really his driver? Probably not, right? Could be his pain generator. He has left foot pain. He probably does. Some pain generators probably in his lumbar spine, but that's not his driver. They're two different things, right? Calf tears, his feet. Definitely his foot is on my list because I've seen it. I've seen people who have, the foot's a big driver in many, many injury patterns, guys. So just, I've mentioned this many times before. Get good at assessing your feet, okay? So with him, the thorax would be top on my list, okay? He's got issues in his biceps tendon surgery, proximal humeral fracture. That would sort of go with the shoulder thorax area, okay? And his feet would be the top. I would say the top 2-3 areas, right? Yes, he has hamstring tears. Would his pelvis be on the priority list? Yeah, but wouldn't be high. It would not be high. Okay, so before you even assess a movement pattern, and I would suggest that, Susan and I did actually the last episode, 123, is about how to pick a functional movement pattern with your patient. And that is, one that's meaningful for them and one that they can connect to. So I highly recommend that you listen to that. It's a shorty. It's probably about 15 minutes, okay? So that is something that I would highly suggest that you listen to. Because you're going to use this narrative and you're going to pick a movement pattern or patterns that will give you the most bang for your buck and where you'll find your driver, okay? So to be clear, this guy had left foot pain with office sitting. Cross-country skiing made him feel better. Cycling with the narrow arms and the curved arms didn't feel good. It's a very narrow base of support with the arms, right? He could not compensate anywhere. He couldn't compensate in his foot because he was clipped in, right? Couldn't compensate. And so he really felt it in his foot after cycling. Okay, the big thing was the office sitting, though, okay? So what we're going to do in terms of priorities and movement history, think about, okay, do you think his movement history with his rowing is relevant? Of course it is. He was a left sweep. When I tell you, I took a picture of him in standing with his feet narrow. He was so far over to the left, I thought he was going to collapse. Trust me. Someday we'll do a video of our podcast and I'll pull up, pictures, but he was so far to the left. I just took a picture of him, marked it up on my Apple preview. His whole left side of his body. It was so very, very ingrained in his brain, right? You imagine loading that left side for so long because it's a movement pattern that he's had forever. His right side has lost options for movement. Okay, you need to get him out of that pattern, okay? Which means you need to find the driver or drivers and get the job done, okay? And that means performing or designing a treatment program in terms of exercise geared towards that driver, okay? And you need to get him out of that movement pattern based on the narrative and based on this movement history, okay? So with him, you think about, yes, his movement history probably is the main factor or the main clinical pearl I want to impart for this case, okay? Think about what the patient's been doing forever. It could just be sitting. It doesn't have to be a sport, but it's something they've been doing a long time. The body develops habitual movement patterns. We know that. But over time, those patterns become relevant to why they're coming into your office. And think how you can weave that in to a clinical movement pattern that you can assess. That's with our last episode, 123, okay? So just for the record, with him, because he had a problem sitting and because I needed to look at the thorax, the foot, the shoulder, I assessed a squat with a bilateral arm lift. He had a problem sitting. A squat was the most obvious movement to assess. Took into account all of his injuries. Okay, remember that. You need to assess a movement that's going to take into account your regions of the body that you have prioritized based on their movement history and based on their past injury history. So this guy, The relevant piece of his story and his narrative was the movement history, the movement patterning of rowing. Okay? They brace their scapula, brace their thorax. Okay? They're grippers. Okay? So the second and the last example I will give, it's actually going to be a tennis player I treated. It seems like I treat a lot of athletes, but I do treat other non-athletes as well. Just athletes are kind of really interesting. They're the best compensators going until they can't, right? So this particular person, her issue was she could not do a push-up without neck pain. Erica, my right side of my neck hurts. She puts her hand on her traps, her SCM, the whole supraclavicular fossa. I can't do a push-up without neck pain. It really bothers me. Okay, high-level tennis player, when she was younger. Okay, not anymore, but extremely active. History, her injury history. Bilateral anterior compartment syndrome, right worse than left, when she was a competitive player. So she's probably now in her 30s. Not too long ago, right? She's also was postpartum a year when I saw her, and a lot of bloating and digestive issues. Okay, so that was her injury history. I happened to ask in the history and the narrative, did she have heart palpitations? And Susan and I have talked about like the top questions to ask, right? And heart palpitations for me is on the list. I ask it of pretty much everybody. She had heart palpitations, but she was worked up and nothing was found. So just note that put that in the back of your brain, okay? Her movement history, high-level tennis player. What do we know about tennis players? What do we know? A lot of compression in their thorax, a lot of compression in their shoulder girdle. That's obvious, right, by the nature of their movement pattern, right? There's a lot of weight shifting going on, right? A lot of agility versus like golfer, where they're more, golfers tend to be more center of mass and weight shifting. It tends to be more important, superimposed with rotation. But tennis players have the ability, or they need the ability to come in and out of movements very quickly. Okay, and especially with right-handed tennis players, a lot of compression in their upper ribs, 2, 3, 4. Okay, and also compression in their GH. Right, that's her movement history. And her injury history, as I said, bilateral anterior compartment syndrome, and a lot of bloating and digestive issues, along with heart palpitations. So what are we thinking, guys? She can't do a push-up without neck pain. My neck hurts. I can't do a push-up. Okay, a push-up's a full body movement, right? Pretty much, even though it's upper body focused, it's a full body movement. You got to get your feet on the ground, right? So just think, same with my last guy, how would you prioritize this? Similarly, right? With her, you want to think about her feet, mostly her right foot, right? That's got to be high on your priority list. It's one of her major injuries. She had it for years. Okay, she had bloating and digestive issues. That's going to be obviously the thorax, right? And based on her movement history, she's got, it takes into account her thoracic spine, her GH, and her neck. So you've got a lot of different moving parts with her. So her neck is obviously meaningful for her, so it's got to be on the priority list. Based on her injury history, you've got to look at the feet. And based on her movement history, you have to look at the thorax and the GH. Nothing else, no other priorities for me. Okay, so you just, you're sitting there, just picture yourself, you're sitting there, this patient comes in, you get her movement history, you get her injury history, you do what you do. And now you're thinking, okay, I need to stand her up, I need to get some form of a movement to assess. Okay, you've done your straight line, your chronology. The foot injury set her up, right? Definitely set her up. Okay, and now you're drawing your line. Okay, then you're going to put on another piece of paper, however you do your evals, neck, feet, thorax, GH. Okay, and this is episode's not about assessment, right? So, however you assess, but I want you to think about priority areas. And if you're have a patient that hasn't gotten better or has plateaued, think about, go back to the eval and see if you look at the past injuries. I know Susan and I have beaten this one to death, but every injury is important. And people come in with pages, and I mean pages of injury history. I had a patient right before the pandemic. She literally said to me, it all started with my clavicle fracture. This is in January of 2020. I was like, oh boy, 3 pages of injury history later. And one of her drivers actually was her clavicle. So these people know. They're pretty married to their injuries, right? So once you start giving them, talking about their narrative and giving them, some what's the word? Just a little bit of help along the way about, any foot issues, any injuries. Nothing is too small. What did you do as a child? Really important. Trust me, it will save you time. It really will. So with her, we've got our list, right? Okay, so what do you think, what kind of a movement are you want to assess with her? Okay, based on her injury history and her movement history. This is going to be a little bit different than the first guy in the rower, because he was pretty straightforward with sort of the squatting. But you think about here, in her narrative, foot, thorax, GH, neck. Right, I can't do a push-up, Erica. I can't do a push-up without neck pain. What are you going to do? How are you going to assess it? You've got your priority list. You've got your timeline. You've got your hypotheses as to the driver. What are you going to do next? How are you going to shave 10 minutes off your evaluation? Okay, are you going to look at a push-up? Yeah, you're going to look at a push-up, right? It's meaningful to her. That's the movement. That is meaningful, and she will have a connection to that. Okay? Can you effectively assess the foot that way? A little bit. You can have her go narrow with the feet doing a push-up, for sure. And I did do that. Okay, you can have her go wider with the push-up, see which looks better. You can have her go normal, narrow, wide with the arms. Susan and I have talked about this many, many times. Okay, because the bilateral anterior compartment syndrome was high on my list, the feet were high on my list, I did assess another movement as well. Okay, because I needed to see her strategy outside of a push-up to see if she used the same strategy. I had her do a narrow base squat, feet close together, and do a squat. When she did that, she offloaded her right foot and went completely to the left. And when she was on the wall, so I had her just do a basic push-up on the wall, and she went way to the left. So I saw the same movement pattern in a narrow-based squat, as well as the push-up on the wall. So I chose those 2 movements based on her narrative, based on her past injuries, and based on her movement history. Okay, because the thorax was high on my list, I knew the push-up would get it. Okay, because that's what she couldn't do. But I knew that I can assess that fairly okay. If you don't have confidence in assessing that, you can have her do something like a narrow-based squat, because you want to look at the foot, its contribution to her strategy. That's what I'm trying to get across here. Her foot is part of her past injury history. You need to be able to get a look at that foot in a couple more movement patterns. Those take 10 seconds to look at, right? It'll be obvious. She went way to her left. I had her in front of a mirror, and she went way to the left. So clearly she was offloading. Something's taken her left, right? So based on her narrative, I decided that the foot was definitely going to be a player. Okay, I knew it was high on my priority list, and I knew that when I assessed the push-up on the wall, that I had to think about effectively bringing the foot into that picture, like a normal, narrow, wide with her push-up on the wall. Then we go back to her past injury history and her symptoms, right? She has heart palpitations. Where does the cardiac sinus sit? It's in your thorax. Another clue in the narrative, okay? So I'm going to say this twice because this is very important. She will display a movement pattern related to her strategies in competitive tennis, as well as her adaptations to her previous injuries. I'll repeat this again. She will display a movement pattern related to her strategies in competitive tennis, as well as her adaptations to her previous injuries. I talk about adaptations. That first injury sets them up. Okay, my competitive rower, you can just put competitive rowing in there, right? With her, it was a combination of her movement history and her injury history that drove me or helped me to find her drivers quicker. Her driver was her thorax and her foot, as well as her glenohumerus. She had a few, okay? That's another episode. But the rower, it was mainly his movement history that led me to his drivers, okay? So that is why the narrative is so important. It will help you find your driver quicker, and it will help you figure out a movement pattern you can assess that will take into account all of these. If you only had her do a push-up on the wall, could you have effectively figured out her foot? Maybe, maybe not. If you had her sit and have her turn her head to the right, to the left, lift her arms up, you would have missed you would have missed the foot, okay? You would have missed it completely, okay? And the foot was a huge driver for her, okay? So think about what's important in the narrative and how you can draft and craft a really good movement assessment. So guys, I hope that helps, and any questions, you know where to reach us, and we will see you on the next episode.